you've got most of that. CR capture is supposed to be going away on the next registry. Y'all might see it, but the class that follows you is not supposed to see it. Remembering the CR capture, what we have are the photostimulable plates that we have to load into a reader. Anybody still see any of those anywhere? I think the last place we had one was out at UT and nobody used it.
They finally took it out.
They finally took it out, so we don't have CR anywhere. Okay, and that's why it's going away. It Medicare, Medicaid made a requirement that if they were going to receive funding, then they had to go to digital imaging. So that's why that was being phased out, as it kind of should have been. It's old technology, and the dose to the patient is roughly twice as much with CR as what it is with DR. So really, and the price of DR had come down to the point where there's just no benefit to having a CR room. The only real benefit, and just to discuss the history of why CR came before DR initially, because the technology was emerging at the same time. CR beat DR for the most part, but it was a cheaper transition from screens and films to CR than it was to go to DR. With DR, the entire room had to be changed out, and you had to have a computer that articulated with the image receptors. Everything had to be replaced, whereas with CR, what they had to do was just replace the screen film cassettes with the photostimulable phosphor cassettes, and then replace what we refer to as daylight processor, which was a film processor, with the CR processor. So fundamentally, it didn't really change anything in the workflow, except for you would scan the patient in instead of have to flash their name on the film. But aside from that, it really was familiar to everybody. So it was cheaper, and it was seamless in transition pretty much. And then, of course, DR came along, dose went down. The reason the dose went up with CR is because CR cassettes and image capture was half as fast as screens and films. Okay, so that's one thing that we're going to talk about is speed, relative speed. And this is review. You got this in the second semester. But speed is sensitivity to exposure and processing. So the relative speed of screens and films was 400 speed, and CR was 200 speed. So what that meant was that in order to get the same image, we had to do one of two things. Either increase mass, which is generally what you would do with slower speeds, you would increase mass. And with that increase in mass, naturally came an increase in patient dose, right? So patient dose doubled with the promise that we would shoot fewer repeats, and therefore the potential for overall dose would decrease. So that was a selling point for CR. Film storage went away, it was all digitized, and there was the potential for cutting back on patient dose, even though for an exposure patient dose went up. So along came DR. Well, let me stop there. So with the CR image creation, the computer algorithm is what controlled the contrast. So with that control of contrast, instead of KVP, then what we could do is, instead of increasing mass and doubling patient dose, we can increase KVP. So instead of doubling mass, we went up on KVP by 15%, exactly. So did that increase the patient dose? And the answer is absolutely increase the patient dose. Remember that if the only thing that you increase is KVP, or the only change that you make is to KVP, your patient dose goes up. Doesn't double, but it does go up. Now we get to DR, and DR had the same relative speed as film, screens and films, maybe even faster, okay? But it still had that digital processing, so KVP didn't control contrast. And because KVP didn't control contrast, we could leave that KVP high and now cut our mass in half, and that's when the dose came back down. Okay, and that's part of the reason I think that Medicare and Medicaid wanted to go with DR rather than CR, and the reason that CR has been phased out. So let's speed. Unfortunately, we lost some resolution. I think we talked about it last week. The individual detectors are small or larger than what the individual phosphors were in screens and films. So we lost some resolution, but the dynamic range was so high that we could ferret out contrast that we couldn't see before, and that was the payout. So where we got lower resolution that we really couldn't see anyway, we got such a high dynamic range sort of being like grayscale, only better. It's kind of like grayscale with high contrast. It's kind of weird. We could see things that we couldn't see before. So that was the payout with it, that we got a whole lot better. So of all that. So all of this you should get in your you know, the ASRT modules. So CR plates look a lot like imaging plates, the screen film imaging plates. So you can read through that. There's some notes at the bottom of the PowerPoints that are in Canvas if you would like to. So the one thing that we encountered with DR is that the potential for quantum model increased. So what is quantum model caused by? Inadequate mass, right? So here we have these high-speed image receptor systems, very high-speed image receptor system. We increase KVP and we decrease mass, then the potential for quantum model was introduced. And the image receptors have become so sensitive that it's very difficult to demonstrate quantum model. In anybody's experiments, have you seen quantum model? It's kind of a speckly looking appearance on the image. Looks like bad reception on your TV or something like that. But that's what quantum model is it's a modelly appearance because not enough mass, not enough photons hit the image receptor. And you might not, whoop, that's not what I wanted. You might or might not be able to see the grainy looking appearance on that until I dim the lights. There we go. Now you can see it a little bit better. So that's grainy looking appearance on the image. So with DR, not so much with CR, but with DR, because of the high KVP and the lower mass values, the potential for quantum model increased. So that was one potential drawback to that switch to DR. So just real quickly, we're going to talk about the H&D curve, and we've talked about this before. The H&D curve was what we used to measure image contrast in screens and films. And we don't really use that anymore. And what the H&D curve was we would graph out our exposure versus our response on the image receptor. So what we had was we have an exposure axis and a density axis. So if we have a image receptor system that takes off at a 45-degree angle and goes up like that, that would mean for every unit of exposure, we get an increase in density that's proportional to the unit of exposure, right? And the actual DR response is this, okay? But we don't really want it to look like that. If we had every image that looked like that, it'd be low contrast. So what we do is, in your lookup table, what they do is they take and a radiologist, a couple of radiologists, sit down at a computer whenever you get a new system. They show them all different kinds of exams: fingers, hands, wrist, forearm. I mean, pretty much everything that you're going to shoot in that particular room. They'll show them maybe 6 different images. They'll say, okay, I like image number 3. And that image will become the foundation for your lookup table, okay? So maybe you're looking at hands. Well, you're looking at hands, you're looking at bones. And if you're looking at bones, you want high contrast, right? So what they'll do is they'll pick the one that's most pleasing to their eye, that they feel like they can make the best diagnosis off of, and that'll become the foundation for their lookup table. But the lookup table is just a range of densities so that you see these little spikes and valleys, you know. And it's kind of hard to make sense of what you're looking at. But what we do is we apply a H&D curve to the, you know, as a visual representation to the lookup table. All right, so if we have, again, a response that is completely linear and it goes off at a 45-degree angle, I said that would look like low contrast, right? So if we have exposure, if we make an exposure and for every unit of exposure, then our density goes up higher, then we're going to get from light areas to dark areas a whole lot faster. Okay, so what kind of contrast does that sound like? Does that sound like high contrast or low contrast? We go from light to dark real quick. High contrast, right? It's high contrast. So if it takes more exposure to make it dark, then that's low contrast, right? So visually, if you get deep enough into the, you know, super user screen and whatnot, what you'll see are your lookup tables, and they might be represented by an H&D curve. So if you see an H&D curve that's very vertical, like that, that would mean that it's representing a lookup table that is high contrast, as opposed to one that's very horizontal, more like that, and that would be low contrast, okay? Because of the inherent high contrast in the chest x-ray, we want to apply a low contrast lookup table to it so that it doesn't look like a set of ribs. Make sense? If we're looking at bone, we want high contrast, so we're going to, you know, assign this very vertical lookup table to the ribs, so chest x-ray ribs, right? So the H&D curve is still relevant in this context only. What we used to have to do is really, more than anything else, we were assessing processor chemistry and whether or not it was exhausted. Processor chemistry, kind of like the motor oil in your car, eventually would just, it wouldn't be as effective as what it should be, and you had to change it all out. So every day we'd come in, we'd make an exposure, not with the x-ray tube, but with this thing called a densitometer, sensitometer. We make this image on an x-ray film with sensitometer and then process it and then look at it and see what it did was it put an image of a step wedge, and we would see how high contrast it was showing us, you know, what the exposure was actually giving us. So in that we could assess whether or not our chemistry needed to be replaced. So that's the foundation for the H&D curve and where we still use it just as a visual. It's a whole lot quicker to look at a single line as opposed to a number of different lines and say, well, you know, you got so much room in between these peaks and these valleys, and that's, you know, high contrast versus low contrast. It's just immediate that you can look at it. So that's your H&D curve. So straight line portion is the portion between 0.25 and 2.5 densities, and where those lie is, you know, the 0.25 is way down here close to the bottom, 2.5 is right up here somewhere, 4.0 is an image that's so dark you can't see anything. Okay, and by that what I mean is if we had a film, an actual radiographic film that was at 4.0, what that meant was you could put that on the window as a shade and no light's getting through the window. So that number, that 4.0, is actually logarithmic. You know, it's a logarithmic number. So what a log is kind of like exponential form. You take a small number to represent a big number, all right? So what 4.0 represents is 10,000. So if we have an X-ray film that the density is 4.0, What that means is 1 out of every 10,000 light photons get through that film. Okay, so the useful range of densities lies between these, 0.25 and 2.5. Okay, anything above that is too dark to see anything. Anything below that is too light to see anything. So those are your useful range of densities. So all that's explained in the PowerPoints. So a couple of things, artifacts that we didn't see before we went to CR, aside from the the quantum model that we talked about before. One is dropout artifact. So what a dropout artifact was, or is, if you ever still work with a CR system, is that the phosphors can be one of a couple of different orientations. Either the phosphors will be kind of a powdery substance that they put on the face of the plate, or they'll be what they refer to as needle phosphors. Needle phosphors are long and skinny, kind of like these things. And if one of the powder phosphors just doesn't fire, they're usually so close together and there's light coming from above and below them that if it doesn't fire, you're probably not going to see it. But needle phosphors are they're two-dimensional, three-dimensional. So they, if one doesn't fire, that means that entire area, small as it might be, is not going to have any density at all. So what it'd be like, let's see if I can do this without this collapsing, is I pull this out of the center of this, and I'm left with a hole, okay? So you wind up with a really bright area on the image, okay? That's what we refer to as dropout artifact, is because that phosphor, it didn't physically drop out, but it quit working. So it doesn't work anymore, it dropped out, right? So that's dropout artifact. Non-uniformity could be caused by a number of different things. Specifically in CR, what it might be caused by is in the reader. So with the CR reader, what you have are two different things. You've got two different types of scan. So you load the plate inside of the reader, and the plate travels across kind of slowly while you've got a laser light that scans real quickly. So you have two scans. You've got slow scan, that's travel of the plate, and you got fast scan, and that's the scan of the optics. So the optics go up and down and up and down and up and down, and it just swivels. Mechanically, the more motion you have, the more problems you could introduce, right? So instead of having the entire laser go up and down, then what they had or still have is the laser just pivots, okay? So knowing what you know about electromagnetic radiation, it emits from a single source, and then it does what? Diverges, right. So what we have to have in order to make sure that laser doesn't diverge any are focusing optics to make sure that the size of the laser remains the same at the top and bottom of that plate. And if it doesn't, then what you're going to have is you're going to have more stimulation at the bottom of the plate than what you have at the top of the plate. More phosphors are going to be stimulated at the bottom of the plate than the top of the plate. Okay? So what that's going to do is it's going to release more light. So then you've got a difference in uniformity between the top and the bottom of the plate. Okay, so the darkness, the densities don't look the same on one end of the plate versus the other. Spatial accuracy, spatial resolution issues, very similar to screens and films, but kind of reintroduced in CR and DR. Then we've got erasure issues. Those phosphors hang on to, even after they're stimulated and they release the light, there's they maintain some of that energy inside of them. So if you were to take that plate and you don't run it through the eraser bank and you take it back up and you make an exposure on another person, then what you're going to have is what we refer to as a ghost image. So it looks like it's double exposed. It's not truly double exposed. It just wasn't erased. Okay. So where we have incomplete eraser is most of the time when we don't have adequate lighting in our eraser bank. So how they're erased is that they're exposed to just a big bank of bright fluorescent lights that release the rest of that energy. And if we have burnout lights in it, then it might not release the rest of that energy. And then you go make a second exposure and you've got incomplete eraser and you've got ghost imaging, okay? So a word that you might see is what we refer to as metastability, okay? So what metastability is where those phosphors are excited and they're energized. So you make your exposure and they're you know, the image, the latent image is still on the plate, and the phosphors are elevated to a higher state of stability, and it's what we refer to as metastability. That'll fade over time. So another issue that we have with CR plates is you make an exposure and you've got, you know, an hour's worth of portables to do, it's going to lose some of that metastability before you get it processed. Now, is that 1 hour going to interfere with the diagnosis? Maybe, maybe not, probably not. But after about 8 hours, there's nothing there that's worth, you know, the image is garbage. So there is a kind of an expiration on those. One other thing that's not up here is what we refer to as a moire artifact, and y'all seen that over and over again as you take, you know, photographic images of the x-rays that you've made. And how moire artifact works is that if you have similarity between, you know, the pixels and the, you know, the imaging matrix on your camera versus the imaging matrix on the screen that you're shooting, you get those squiggly lines, right? And where we had a problem with that was with the grid ratios, or really the grid frequency, not so much the grid ratios, but the grid frequencies that we were using were too similar to the scan pattern in the CR reader. So we didn't want to sacrifice grid ratio, so what they did was they maintained the same grid ratio, but increased grid frequency. So what they did effectively is they took this grid, you know, 10-to-1 grid maybe, 8-to-1 or 10-to-1, 12-to-1 grid. They cut it in half and then kind of shuffled the pieces together so that instead of having, you know, your grid frequency looking like that, it's more like that, right? So instead of being thick, it's thin, and it, you know, they shuffle them together so that you have a higher grid frequency, thinner grid strips, height-wise, but more of them. So maintain the same grid ratio by increasing grid frequency and making a thinner grid. So that's moire artifact, also referred to as an aliasing artifact, A-L-A-S-I-N-G artifact. They mean the same thing. Okay, so any questions on all that? That's as deep as we're going in lecture into CRDR. Okay, so then geometric factors. When we talk about magnification, SID and OID issues, distortion, part beam alignment. You know, keeping in mind that magnification is distortion. It's just size distortion as opposed to shape distortion. So when you're looking at questions that ask about distortion, always assume shape distortion unless it specifically says size. Okay, so distortion, both of them are distortion. Magnification is size distortion. If the question just asks about distortion, just think elongation and foreshortening. So that's either going to be the angulation of the central ray or the image receptor causing elongation and angulation of the parts to cause foreshortening. Then we've got focal spot, and then we've got anode hill effect. We're going to talk about where it's better, where it's worse. So SRD, spatial resolution. That's sharpness of recorded detail, the things that affect it. We'll talk about that. So how we test it is with line pair per millimeter test tool. We took a look at that last week. Star test pattern, I don't know that this is still accurate, with the star test pattern being the most accurate, because we've got a number of different things controlling resolution. But what the star test pattern was a test tool that was circular, and it had converging lines that came into the center. All right, so obviously the closer to the center those converging lines got, the harder it was to see the difference between them. So the interesting thing about the STAR test tool, and it had 4 different sections to it, but the interesting thing about the STAR test tool is that you would look at it and the lines would blur, and then they'd clear up and they'd blur again. So those inner blurred lines would be what you were looking for. You had to multiply that by like 0.035 or something like that to get to the actual focal spot size. So what the line pair per millimeter test tool gives us is what our actual focal spot size is, and we can compare that to the stated focal spot by the manufacturer. So the thing is, though, that we've also got test tools that are built into the computer. With CR and DR, we have to not only test what the actual focal spot size is and the image receptors, but we also have to test the resolution at the monitor. So those are built into the computer. It should be done periodically, just to make sure that the computer is, giving us a good image as well. So also test for brightness. All right, so modulation transfer function. I brought the wrong textbook. I'll see if I can find it real quick. Nobody's got their textbook out anyway. So modulation transfer function is, page 211 should be pretty close to it. Here. No, 192, no. Okay. So in this textbook, it's on page 192 and 194. So in your textbook, it should be page 211. All right, so modulation transfer function is a term borrowed from radio electronics that has been applied to the description of the ability of imaging systems to render anatomic objects onto an image. Objects with high spatial frequency are more difficult to image than those with low spatial frequency. All right, so spatial frequency, how often something happens, right? So how close things are together. This is just another way of saying that small objects are harder to image than large objects. All right. So regardless of the size of the object is considered to be high contrast, black and white, for the purpose of modulation transfer function. The ideal imaging system is one that produces an image that appears exactly as the object. Such a system would have a modulation transfer function of 1. So it can be viewed as the ratio of image to object, viewed as the ratio of image to object as a function of spatial frequency. So what to take away from this is that what we're looking at is sharpness of recorded detail with contrast applied to it, high contrast applied to it, essentially is what it is. So small objects positioned close together are hard to identify as separate from each other. It's just spatial resolution, right? High spatial resolution is required to image items with high spatial frequency. Without good contrast, 1 and 2 don't really matter. So again, this is going back to what we were talking about last week, is we lost some spatial resolution, but because we got such good contrast resolution with our dynamic range, our bit depth and all that we could afford to lose just a little bit of spatial resolution to get that contrast resolution. The anatomy that was so small that we were having a difficult time seeing it anyway, Without the contrast, we couldn't see it anyway. Now we've got the contrast. We might have lost a little bit of sharpness reported detail, but not enough to interfere with the imaging. Okay. So magnification, again, size distortion. Occurs with changing SID and OID. So we have to make sure that our SID is accurate. You know, OID, your job is to put the image as close, or the object as close to the image receptor as possible to reduce OID. Right? Can't always do that, but that's what you hope to do. So the rest is up to the machine, right? So backing up 72 inches where appropriate is your job, but how do you know whether or not you've got 72 inches? Well, for quality control purposes, the distance indicator has to be within 2% of SID. So if you're at 72, well, we'll say 40 inches because it's just easier. So if 40 inches, 2% of 40 inches is what?
0.8.
0.8, very good, 0.8. Just like the pennies from last week is 0.8, right? So it's got to be, you know, pretty close. If you're, you know, showing 40 inches and you're actually at 39 inches, then, you know, somebody needs to come in and kind of tweak your machine. So there's a number of different distance indicators. One would be, you know, of course, the mark on the ceiling, you know, it's got to be accurate. One would be on the tube itself. Sometimes you have a tape measure that sticks off the front of the tube, especially in portables, right? So how many of y'all worked with your dad when you were a kid? Used tape measure? Yeah. What would get you smacked using a tape measure quicker than anything else? Yeah, you just did.
A lot of things.
Well, a lot of things. You pull the tape measure out, right? You measure what you want, and then you just let go of the tape, and what happens? Yeah, Primo got it. It comes back in, it'll knock the end of that off if it gets done too often. So the first thing that the physicist is going to look for is the tape measure acceptable or accessible? Or, you know, was that little thing knocked off the end of it and it's sucked inside of the collimator housing? So is it present? Is it accurate? Right? And if you look at that tape measure, whenever you pull it out, keeping in mind that what you're measuring is the distance from the focal spot inside the X-ray tube to the image receptor. We have a tendency to look at the bottom of the collimator housing and say that's, you know, that's where 72 comes from. But if you look at the first number on that, what do you see? Anybody ever pay any attention? What's that? 10, 12 inches, right? So that's from the bottom of the collimator housing. What we're measuring in this is from the focal spot. So it's, you know, it's from inside of the X-ray tube to the focal spot. So if you look at that, and it says 10 inches or 12 inches, that's because that's the distance from the focal spot to the bottom side of the collimator. It's not that it's inaccurate, it's that it's compensating for that, okay? So with magnification, magnification is always present. It's always present because you can't put the anatomy of interest directly on the image receptor. Even in thin anatomy like hands, you've still got a little bit of OID because of the skin, right? You're looking at the bones, but you've got, I don't know, a 1/4 inch worth of soft tissue before you get to the bone. So you have some OID. It's not much, but it's still there. So magnification is always present. So when you're working your magnification ratio problems or degree of magnification, percent of magnification, what does 100% represent? Not 100% magnification. What does just 100% represent? If I gave you all of something, how much of that something would you have?
All of it.
All of it, which is percentage-wise 100%, right? So the object size is always going to be represented by 100%, which means magnification is always going to be above that. So if you're working your magnification ratio or percent of magnification problems, percent of magnification is always going to be 1 point something. Always going to be 1 point something. If you work it out and it's under 1, you work something wrong. right? You plugged in the numbers incorrectly somewhere. So it's always going to be above 1, never going to be below 1. So, you know, if I gave you a question that asked you, you know, the object size is 1, the image size is 0.8, what's your magnification factor? It's a flawed question. You know, it's a none of the above, right? Because the object size is always going to be smaller than the image size, even if, you know, okay, taking into consideration that the image size, the display might actually come up smaller than the actual object. The magnification inside of the computer is always going to be above 1. And that's why I still can't figure out y'all's, you know, I don't know, your earpod case? I don't know. Maybe your tape measure was wrong. All right. So anyway, it's always present, especially with spherical objects, and that is because you can't turn a spherical object, and it may say round, but it's really spherical, because a quarter is round, but how thick is a quarter? Yeah. So the better description is spherical shaped objects. You're always going to have magnification present because you can't put any part of that spherical shaped object any closer to the image, right? It's just the same distance from any direction. The closest thing that we've got to that is the skull, right? So from a lateral, the fattest portion of the skull is right there, right? So if I turn around this way, does that help? No, it's still in the same spot, right? Back of the skull, same way. From the side, the fattest portion is right here. Okay, you can shoot PA, and because this is not directly in the center, you're going to get a little bit less magnification AP than what you would PA, but it's still, you can't get close to the image receptor. So keep that in mind. You'll have questions about round objects and magnification. They always show magnification. Okay, so 3 different ways to calculate magnification factor. We've got all those. And of course you'll have everything except for one of the elements. Keep in mind that if you have one where you have to calculate SOD, make sure you don't miss that step. Probably the most common thing that people will do is do like, I don't know, SID over OID. Okay, and that's just not going to get you there. So you have to calculate your SOD. So SID minus OID gives you your SOD. Always greater than 1. Just talked about all that, so I'm not going to go back through that. So our most common SIDs are 40. I put 48 in parentheses here because for 2 reasons. One is that Merrill's for a while was kind of toying around with trying to make 48 inches more standard on all images. So instead of shooting KUB at 40 inches, shoot 48 inches. I don't think, I haven't even thought to look because everybody just ignored it because everybody was shooting 40 inches still. But I haven't thought to look in the most recent edition of Merrill's to see if they back that back out. There are times that 48 inches is a good idea. Like for example, if you're shooting a tib fib, at 40 inches, you might not be able to get your collimated field open wide enough to get, you know, proximal and distal, 1.5 inches, 2 inches proximal and distal to the tib fib. So you may have to increase your SID just a little bit to get there. And 72 inches if we want to decrease magnification. So I kind of played around with SIDs, you know, back when I was working, you know, trauma. And, you know, the reason we shoot lateral C-spine at 72 inches is decrease magnification, right? But with the increase in SID, what you also get is a decrease in the divergence of the central ray. At 40 inches, the central ray diverges so much that on a lateral C-spine, you project the C-spine down into the downside shoulder, right? Unless you position way down here, right? So where you put the central ray perpendicular to C7T1. And then you're going to have to open up your collimators to include the entire skull and half of the T-spine. So that doesn't work. So we shoot at 72 inches. I played around for a while with trying to get an even more perpendicular central ray. I started shooting lateral C-spines on minor traumas at 10 feet, right? Thinking if 40 inches is bad and 72 inches is good, 10 feet has to be better, right? And it doesn't really increase the patient dose. It's harder on the x-ray tube, and it didn't really do any good. So I abandoned it after maybe a month of playing with it. It didn't really, there comes a point of diminishing returns. Yeah, it's harder on the x-ray tube. It's harder to get you've got to calculate a whole new technique. It just wasn't worth the effort. The juice wasn't worth the squeeze, so to speak, right? So I just quit. Went back to 72 inches. So 72 inches is adequate. Keep in mind that if you increase your distance, you are going to change the exposure, providing you don't make an adjustment to your technique. So the change is because of the inverse square law, and we have to apply the direct square law. Sharpness, we should see a greater, even if we don't see it on our monitors, there should be a greater amount of sharpness on the radiologist, their high resolution monitors. So decreases magnification has no effect on contrast, but it does change density pretty significantly. So SID, notice we've got that's probably the left costophrenic angle projected off the image receptor. With it, this is supposed to be at 40 inches, at 72 inches, we can see it all. And they really should have dropped this down just a little bit to make sure that they got that posterior costophrenic angle. AP versus PA, as positional, so that, if you shoot PA at the thumb, then you're going to have an increased OID. So OID, changes in OID, as we increase OID, then we lose sharpness of recorded detail, we gain magnification. We might have a little bit of a density issue, right, as we increase OID. What's the air gap? How does the air gap work?
Scatter.
Mm-hmm.
Angle.
It's exactly right. Wide angle scatter radiation misses the image receptor. So I took my little pointer stick down to, 0 floor, because that's where we have to have a freshman, because we have 33 of them. And I hadn't seen it in 2 weeks. So that thing has been with the program since I've been with the program. So, and I pulled a lot of splinters out of myself over the years. I kind of got it sanded down with my hands, and now it's gone. So with that wide angle scatter radiation, it misses the image receptor, and it works like a low ratio grid. So with a low ratio grid, I'm talking about like a 3-to-1, 5-to-1, no more than a 5-to-1. You can see, back when we used screens and films, you can see a definite difference between, lateral C-spine using the air gap technique and using an 8-to-1, even an 8-to-1 grid. That was a vast difference between the two. So the science behind it's valid. The wide angle scatter radiation is not going to cover the image, but how effective is it when compared to a grid is just not. So, but, for testing purposes, it works like a low ratio grid because the scatter misses the IR, or at least it misses the part of the IR where the good anatomy should be projected. So scatter misses that area anyway, and because it does, we should increase contrast. Again, theoretically, what's the thing that controls your contrast? Look up table, right? So you look up table. But again, anything that could clean up some scatter radiation theoretically could increase your contrast. So it misses the image receptor is what we call an air gap technique. So the effects of increase in OID on sharpness of recorded detail increase OID, increase magnification, decrease sharpness or reported detail. Don't tie these two together. You don't lose sharpness or reported detail because of contrast, or contrast because of sharpness or reported detail. The loss of sharpness or reported detail is because of the magnification, and because of the magnification we lose, sharpness. And magnification is size distortion. All right. So SID and OID, again, your SID comes from inside of the X-ray tube and not the bottom of the collimator housing. So SOD, again, when you're working your magnification factor out, if it's calling for SOD, make sure that you don't skip that. That's source to object distance. So if you have changes in SID or OID or both, it can affect magnification. With the effect on magnification, it can affect your sharpness or reported detail, and that is your penumbra. Okay, so how you control it? Lowest OID possible, longest SID practical. Again, 10 feet, just not practical. So lowest OID possible, and it does increase with grid use because grid does add a little bit of OID. It does increase if you're shooting into the bucky because again, you've got not just the grid, but you've got the distance between the tabletop and the grid, and then the grid and the image receptor. So when you're looking at a OID, the lowest OID you can possibly get is to put the anatomy directly on the image receptor, right? That's not always practical though. If we're going to shoot something that's going to create a lot of scatter radiation, then we need a grid. Again, we're back to sharpness of recorded detail versus visibility of recorded detail and whether or not we can see that sharpness. So we don't want to lose the dynamic range. We don't want to lose the contrast. So, you're shooting a KUB, unless it's a really, really thin patient, or unless you're shooting something specific like, and you don't have grid, you walk into the patient's room and they want to see where the NG tube is going to be, right? What are they looking for specifically when they drop an NG tube?
Below the diaphragm?
If it's below the diaphragm, is it in the left lung, or right lung rather, or is it below the diaphragm? That's all they're looking for. So if you don't have a grid, is it really worth it to go all the way back down to the department, get a grid, come back up to shoot with a grid? The answer is no. You're shooting a low chest x-ray is essentially what you're doing. If you position for KUB and it's in the lung, then you're not going to see it, right? So you're positioning like a low chest x-ray. Do you need a grid for a chest x-ray? No, because of the natural air gap, right? Do you use a grid whenever you're doing portable chest x-rays? Probably not. You're probably not even applying a virtual grid. You might, but you're probably not. Okay, so unless you're shooting something very specific, then if you get to something the size of a chest x-ray, you need a grid, right? So KUB, you need a grid. Again, unless you're shooting like for NG tube. So it's going to increase OID, decrease sharpness or reported detail. But what we're talking about is, half an inch, 3/4 of an inch. Is that really all that much of an OID? No, it's not. So, but it is testable. You add a grid, you increase OID. So it increases with bucky use, longest SID practical, 40 inches on just almost everything. Might back up to 48 inches on certain things. And then for things where you've got an increase in OID that you can't overcome, or if you're shooting something that you need the divergence of the central ray to be less significant, then you need to back up 72 inches. By less significant, what I'm talking about is if you ever have to shoot AC joints. You ever notice on a chest x-ray, sometimes you'll project the shoulders off. If it's somebody of decent size, you'll project the shoulders off. If you back up 72 inches, the divergence of the central ray isn't as significant and you're less likely to project them off. Okay, so that 72 inches is not just for magnification, but also to get you a more perpendicular central ray. All right, so I don't know that macroradiography is really going to be a registry item anymore because of digital processing, but we're going to go ahead and cover it just in case. What macroradiography used to be was an increase in OID with no accompanying increase in SID. Okay, and the purpose for it was to get magnification. Yeah, we lost a lot of sharpness of recorded detail, so what they did was, this, where we would use this was in interventional cardiac catheterization, things like that, where we'd use C-arms, and what they would use is a fractional focal spot. So remember, we've got large focal spot, we've got small focal spot, and then in interventional we have fractional focal spots, which are very small focal spots, and then in mammo we have micro focus tubes, right? So we have 4 different things to consider in focal spot size. So what we would have is an increase in OID without an increase in SID, so that we get that intentional magnification, and we use a fractional focal spot so that we could get back some of the resolution that we're going to lose by increasing the OID, okay? And again, we'd use that if they were trying to image small vessels in the brain, if they were trying to coil an aneurysm in the brain or something like that, they would use a fractional focal spot, macroradiography, get that increase in OID, get the magnification. So on the test, look for that word, macroradiography. It is intentional magnification radiography. It's an increase in OID, no increase in SID. So you get a test question that says, how do you overcome the loss of sharpness of recorded detail in macroradiography? A lot of y'all are going to say back up 72 inches. And what's going to happen? You're going to get it wrong, right? So your answer is smaller focal spot size, right? So that's that. Now the reason I say that this might not be on the registry anymore is because, and we still use it. If you ever go back to special procedures, they use a C-arm, and they usually use 2 of them. And for simplicity's sake, what they'll do is they'll put the anatomy right in the middle of the C-arm so that if they have to oblique the C-arm, everything still stays lined up, right? So it's still applicable, but where the magnification actually comes from is digitally, right? So they can make it as big as they want to with a click of a button. So they still have to have that microfocal, or the fractional focal spot, but in as much as the magnification coming from the increase in OID, yeah, it probably still affects it, but really, the digital increase, the click of the button is really where they're going to get the magnification. So it might be on the registry, it might not. So distortion, again, if we're talking about size distortion, magnification, then it's always going to come with a qualifier size distortion. Any other distortion is either going to be foreshortening or elongation. So that's your part tube film alignment. Is everything perpendicular? Is everything parallel? The things that are parallel, are they parallel? The things that are perpendicular, are they perpendicular? So elongation occurs with central ray angulation. And it again occurs more with round anatomy for the same reasons we were talking about before, or even if we have anatomy that is very thick in any way, then we're going to get some sort of elongation. It's kind of like the cylinder you showed us last week, right? With any kind of angulation across that cylinder, because it's 3-dimensional, then it's going to travel quite a bit. And it's kind of like that parallax that we talked about before. So, if I can get this perpendicular, or I guess parallel to the travel of the light field, then I get a perfect round shadow, right? But if I bring it over here, it changes quite a bit, right? So in thicker objects, what we're going to get is more distortion. If the central ray is not perpendicular or parallel to everything, it should be perpendicular or parallel to it. So elongation occurs with central ray angulation or tilted image receptor. Both of them kind of give us the same thing. Remembering that all the way back to first semester positioning the things that we could do with a central ray to see anatomy better, like the scaffolding. What did we do for scaffolding? Two things. There were two separate things in the book, but I've never worked anywhere where the radiologist didn't want those two things combined. You got one going there. Yeah, there you go. Ulnar deviation. And what was the other thing? Okay, that's one way to do it, is to, and you're kind of extreme there, you're kind of going
Yeah.
through carpal tunnel, but you can put the hand on a 15-degree sponge, right? So you elevate it and you put it on a 15-degree sponge, or you can lay it flat and angle 15 degrees cephalic. So every hospital I've ever worked in, I don't know why this has not made it into a textbook anywhere. You know, y'all define that, you know, that combination, and maybe you can get your name in a textbook, but every hospital I've ever worked in wanted both of those things accomplished, the ulnar deviation with the 15 degrees cephalic angulation. Stetcher method plus the ulnar deviation. So that's elongation, and then you got foreshortening is just your angulation of the anatomy. So pictures of those. So distortion, degree of distortion depends on the object thickness. The thicker the object, the more distortion you're going to have. Object position, size and or shape, and also its relative position in the central ray, right? So let's say you're in the ER. You got one of those fresh medical school graduate ER doctors. And a patient, you know, they ask the patient, where do you hurt? And they don't really do a clinical assessment. It's just, you know, you got one of these hypochondriac patients that everywhere the doc touches, they go, ooh, ooh, ooh. So they order finger, hand, wrist, forearm, elbow, humerus. If you haven't seen this, you will, right? Can you shoot, you know, like a whole upper extremity? Just one shot. Pow! You know, get one of those long leg cassettes and just shoot the whole thing. Use a stitching algorithm. Can you? You can, but no, you can't. Why? Divergence of the central ray, right? So some of the anatomy is not going to be too badly affected by that. You know, individual digits, no big deal. But what do you got to see on the elbow? What you want to see on the elbow is, you know, your positioning for the elbow is everything in the same plane, thumb pointing up. And what you want to see is you want to see the humeral condyles stacked on top of each other, so it just looks like somebody took a nickel and put it, you know, right on top of the patient's elbow. A perfect circle. Anything beyond that perfect circle, you've got, and we're going to talk about this next semester, you've got some degree of rotation. You've either got rotation where the hand is down, the hand is up, shoulders up, or the shoulders down, one of the four. So if you were to shoot, you know, the entire upper extremity on one image, in order to do that, you'd have to center like right here, right? So what's our central ray doing to our elbow? Yeah, we got an angulation, right? So we got distortion. So what are the important things to see on the elbow besides that? Fractures that we might not be able to visualize. You remember talking about fat pads? We touched on it. We're going to hit it again next semester. But fat pads are soft tissue indicators that a patient has a fracture even if the fracture is not obvious. Right? So in the elbow you have three of them. And one of them is what we refer to as a posterior fat pad. It's not on the test. It's a posterior fat pad. It'll be on next semester's test. And it sits inside the olecranon fossa. Okay, so it's in under the bone, unless you probably have a fracture, in which case it's going to be out of the fossa. Now, again, you've got that central ray angulation. Where is it going to project the top of the humerus? Right on top of your fat pad, right? So, went all that way to say, you know, you get one of these, you know, armograms or whatever it is that some of these doctors want to shoot. Some things can be combined, right? But you can't do like an elbow and a forearm in one exam. You've got to do both of those separate, right? You can do a hand and a wrist. Okay, you can probably talk them into that. Wrist and a forearm, getting a little sketchy there. Forearm and an elbow, no, right? So, so all that way to say that it's not just the object thickness, it's not just the object position, your actual position, but its position within the central ray as well, and object shape too. So shape distortion and quality control. We do what we refer to as vertical beam alignment test. And with the vertical beam alignment test, what we do, if I'd actually gotten here on time, I would have dug this out. But what we have is one tool that tests a number of different things. Okay, so I'm gonna bring this back up. So with this one tool, we can test the accuracy of our collimators, and we can test the perpendicularity of our central ray. All right, so you lock into the table and it says 0 degrees on it. It needs to be 0 degrees. So what we have is we have this tool that is just a square thing, oops, and it's got 2 circles on it in the middle. And then it's got, within the square, it's got another square, and it's got measurements along it. So what we do is we take a cylinder, and the cylinder has a hole on the top and the bottom. Just a pinpoint hole on the top and the bottom, and it's got crosshairs going through it. And this is for beam perpendicularity. So we take the bottom hole and we put it directly on the center of the crosshairs. Okay? And we'll make an exposure. Just put this on top of the image receptor and we'll make an exposure. If those 2 holes are perfectly stacked on top of each other, then we have perfect beam perpendicularity, right? If it's outside of that, but it's inside of that second circle, I want to say it's it's either 1 or 2 degrees of vertical, then it's not perfect, but it's still acceptable. If it's out here, somebody's going to have to do some work, okay? So this same tool also tests for collimators as well. So you collimate down to this area, the inside square, and it actually has measurements on it, so you can see exactly how far off your collimators are. And it also shows you beam perpendicularity as well. So both of those are done at the same time.